Today we will be learning a new chapter, which is chapter number 18, Signs and Symptoms as well as Abnormal Findings. The course series starts with R. The course series starts with R. As you all know that signs and symptoms are which were the reason for admission to the hospital. No patient will be admitting to the hospital straight away stating that I have this condition. Yes, there would be few scenarios if pre-existing conditions are there, they will be coming, or else 95% of the patients, they will be visiting to the hospital or the admission to the hospital with symptoms. Let's take fever, cough, like chest pain, abdominal pain, or leg edema, or leg pain, headache, whatever it might be. They will be admitting with symptoms. After further evaluation, workup and treatment, physician will reveal some conditions, or we may have scenarios where physician cannot reveal that condition, still the symptom exists. Let's learn step by step in which scenario we need to go with R series, in which scenario we need to go with other chapter series, and do we have any other specific categories in this chapter. Let's get started without any delay on it. If the diagnosis established, then assign that diagnosis. What does it mean? If a patient is admitted with fever and physician treated and the result given as some infection, let's take pneumonia. Assign pneumonia as your condition. Don't assign fever, because already they have treated on fever and investigated, treated, evaluated, stating that patient had pneumonia. That pneumonia is a symptom of, that fever is a symptom of pneumonia, right? And then when we need to use symptom codes, the symptom codes we'll be using when definitive condition was not established. When definitive condition was not established. What does it mean? Let's take patient admitted with chest pain, treated for a couple of days, and after treating, investigating everything, physician states that chest pain origin was unknown. Chest pain origin was unable to determine. In that case, still we will be assigning chest pain as your first listed diagnosis, because the definitive condition or the definitive diagnosis was not yet established. Let me give another example. Patient admitted with abdominal pain. Initially they thought that abdominal pain is due to some gastritis or appendicitis. After further treatment, evaluation and everything, they confirmed that abdominal pain unknown source, abdominal pain unable to determine whether it might be whatever it might be. They are completely ignoring, we don't have any source for abdominal pain. In that case, we will be assigning R series, right? We will be coding abdominal pain only. And if the symptom is an integral part of any code, how we will be coding? If a symptom is an integral part of any condition, how we will be coding? Let me give an example. As you all know that GI bleed is an absolute symptom for gastritis, acute gastritis, right? Acute gastritis. As per one of the guidelines, we can assign acute gastritis with GI bleeding as combination code. No need to add additionally GI bleed, right? Here, we need to use symptom when physician mentions that bleeding is not due to gastritis, that bleeding is due to some other source which might be cancer. That GI bleed is some other source which is cancer. In that case, you can assign acute gastritis without bleeding. In addition, assign GI bleed, because that bleeding is due to cancer. That bleeding is not due to gastritis. If there is no documentation, yes, we can by default assign the cause and relationship between gastritis as well as GI bleed. If physician clearly mentions that GI bleed is not due to gastritis, that GI bleed is from another source or another region, stating that, let's take an example of cancer, then don't give combination code. You can assign symptom additionally. Not only in this condition, whenever you are coding any condition, if physician states that symptom is not integral part of that condition, you can assign symptom additionally to give a description or to give an information stating that yes, the patient also has this condition and there is no established condition for that symptom, right? Next, combination codes for symptoms. Do we have any combination codes for symptom? Yes, we have. Let me give an example. If a patient admitted with hypoxia and the patient also has acute respiratory failure, after treating the hypoxia, physician revealed that the patient had acute respiratory failure, which is the reason for hypoxia. Fine. In general scenarios, we will be assigning only respiratory failure because hypoxia is a symptom, right? Let's take previous example, GI bleed as well as acute gastritis. It's a symptom. If there is no documentation of physician, we will be coding combination code stating that acute gastritis with bleeding, right? If there is no cause and effect, we will be assigning additionally. Here, no need to assign hypoxia because the code description states that acute respiratory failure with hypoxia. If the patient is coming for hypercapnia, acute respiratory failure with hypercapnia, we have a combination codes. Whenever we have a symptom combination code with any condition, don't assign symptom additionally. Don't assign symptom additionally. Next, if you see any documentation somewhere stating that repeated falls or frequent falls, in that case you need to assign R29.6 code or 29.6 code whenever you see a documentation of repeated falls. And in few scenarios you will be seeing a documentation stating that history of fall, patient fall 10 years back, 5 years back, 2 years back, like that. History of fall, if the documentation states like that, in that case you need to go with Z91.81. History of fall Z91.81, repeated falls R29.6. Remember these two codes. We have two different codes you need to assign. Next, one of the important topic, which is coma scale. Glasgow coma scale. How we need to assign? Remember one thing, the code series is R40.2. The code series for coma scale is R40.2. You need to remember, whenever you are coding any chart which is related to brain injury or head injury or CVA patient or sequel of CVA, remember you may have a documentation of coma scale somewhere. You need to go through the documents. As I mentioned, this coma scale we can take from any other documents. Apart from physician, we can take from nurse notes, admit notes, ED notes, everything we can take, because this test or this scale will be measured when the patient is arrived to the hospital. That's the reason we can take from any documents. And here you need to remember two things. First one would be whether the documentation states total GCS scale. Let's take the GCS scale is from 1 to 15. If my documentation states total GCS scale is 14, assign a code from R series which states total GCS score 14. We have separate code 14. It will like 13 to 15. We'll be coding that. Now, if there is no documentation like that, focus here. If you don't have total GCS scale, they will give as in 3 parts. They'll be giving 3 parts. The scale has been divided into 3 parts. Number one, motor response. Number 2, opening of eyes. Number 3, verbal response. Motor response, opening of eyes, verbal response. You need to assign 3 codes. If the physician mentions that these 3 things, you need to assign these 3 codes. But whenever you have a documentation of total GCS, don't assign these 3 codes. Go with that single code. If there is a documentation of total GCS, code only total GCS. If there is a documentation of 3 stating that motor, verbal as well as eye response, code these 3 conditions. Code these 3 series. Code these 3 code series, and both the things are documented. Go with total. go with total, because here we are giving an information stating that the patient has this much of scale reading. You might be having a question, what does motor and what does eye response, eye opener, what does verbal? It's and response whenever doctor asks or seeking some information from patient, checking the response of the patient, there would be some scale from 0 to 15 or 0 to 5, like that. Based on that, they will be ranking and they will be giving codes. They will be giving the category stating that the patient has this, patient has that, patient has that condition. We have 3 different codes. We can assign 3 different codes, but don't assign in combination of total GCS. Total GCS is separate, this is separate. Next, if you see any documentation stating that SIRS due to non-infectious conditions, non-infectious conditions might be from trauma, might be from cancer, might be from pancreatitis. There might be a number of reasons for SIRS due to non-infectious process. If there is an infection process, it's fall into sepsis category. If there is a non-infectious category, we have many categories. As I mentioned, cancer might be one of the reasons, trauma, pancreatitis, like that, so on. But here you need to remember 2 codes. We have a series called R65.10, R65.1 series. R65.1 series is for SIRS, but there is a different code when you have with organ dysfunction and without organ dysfunction. If you see a documentation stating that without organ dysfunction, go with R65.10. If there is an organ failure or organ dysfunction, go with R65.11. R65.10 is for without failure, R65.11 is for with failure, SIRS due to non-infectious process. Next topic, death NOS, not other specified. What does it mean? If you notice any expired patient, if you encounter any expired patient, but the cause of death is unknown or the mortality is unknown, in that case you can assign this ill-defined code, which is R99. R99 is the code for ill-defined. Whenever you are assigning or you don't have a code to assign the cause of death or the cause of death was unknown, assign this condition additionally. Note, if you have a specific client guideline, go with that. Usually we can go with R99. Last topic in this signs and symptoms is NIHSS scale. This scale is pretty similar to GCS. We can assign both the scales. This will be mainly for neurological conditions. Whenever you have any neurological conditions of the patient, NIHSS stroke scale, they will be measured. This is only for stroke cases. And remember, these codes are only secondary codes, not first listed codes. These codes are secondary codes, not first listed codes. This GCS as well as NIHSS scale. And the code series starts with R29.7. R29.7. First listed code would be any CVA condition or any neurological condition, followed by this R29.7, which is stroke scale code. These are the guidelines or the different categories we have in the chapter number 18, which is symptoms or abnormal findings. In every chapter we are discussing, or I'm giving few more information stating that what are the categories covered over there. Let me give few codes which are covered in this chapter, like chest pain, abdominal pain, or syncope, or ALS, AMS, abdominal pain, different categories, whatever might be the quadrant, upper, lower, middle, epigastric, specified, unspecified, everything covered in this category. And coma scale, total coma scale, individual coma scales, NIHSS scale, and we have many other codes. Just focus when we need to assign symptom as first listed conditions, and when we need to assign symptom if there is an established condition, and when we need to assign GCS scale, when we need to assign stroke scale, when you need to assign death ill-defined codes, when you need to assign SIRS SIR is something that systemic infectious disease, right? Systemic infectious respiratory system, which is due to non-infectious process or any repeated falls or any other falls, any other combination with symptoms, or when to code a symptom, when to code a category from other listed chapters. We have learned all these things. See you in my next video. Until then, keep learning.